Welcome, I'm Dr. Robert Glatter, Medical Advisor for Medscape Emergency Medicine. Today we have Dr. Paul Pepe, an emergency medicine physician based in Florida and a highly recognized expert in EMS, critical care, sports and event medicine, and resuscitation. Also joining us is Dr. Mick Malloy, an emergency medicine physician based in Ireland, also an expert in pre-hospital care, resuscitation, sports and event medicine. Welcome, gentlemen.
Hey, thanks for having us here.
It's my pleasure. Now, we have a serious event to discuss today. We're going to be talking about what happened to Damar Hamlin, the Buffalo Bills safety, who went down suffering a cardiac arrest in front of millions and millions of people. While we don't know the exact cause of the events that transpired, the goal of our discussion is to really guide our audience through a systematic approach to evaluation and management of an athlete suffering blunt force chest and neck trauma and then suffering a cardiac arrest. We do know, obviously, that Damar was successfully resuscitated thanks to the medical staff and trainers. Almost 50 years ago, Chuck Hughes, a Detroit Lions receiver, went down and died, actually with just a minute to go. Unfortunately, didn't survive. Paul, I'd like to start with you, and you could tell me your impressions after viewing the replay of the events that evening. What were the most likely causes of this syncopal event and subsequent cardiac arrest?
We don't know anything specifically. I'm sure it's being kept private at this point in time about what the events were. It's a little bit complicated in a sense that he basically had a extended resuscitation in the hospital. And my experience has been that most people that have ventricular fibrillation from whatever cause will actually almost be waking up on the field if you get to them. I've had personal experience with that. But I think more importantly, when it starts, when someone goes down on the field, both Dr. Malloy and myself take a more broader view. We don't get tunnel vision and think, oh, it was a traumatic event or it was a cardiac event. And we just have our minds open. So there's a lot of things that could maybe have you stop breathing on the field. Out there, it could be a neck injury, right? It could be a severe head injury. And then, of course, any kind of other internal injury that goes on. But to your point, when I saw the videos that he actually stood up, okay, that makes it a little less likely to be spinal or whatever. And he seemed to be, just more functioning and then suddenly collapsed. That really went along with something that looks like a ventricular fibrillation or ventricular tachycardia even type of event, and made me really right away think, and I was actually witnessing it, that was this, as people call it, commotio or commotio cordis. I'm not a Latin scholar, but it means commotio is like commotion. A literal translation might be an agitation of the heart. And what I was thinking is that probably he got hit somewhere there, and in the middle of the chest, may have hit just right at the right moment where the heart's resetting and in that repolarization phase, like an RNT phenomenon, and then causes this sudden, ventricular dysrhythmia, et cetera. And, most people associate that because we have a couple dozen cases a year with people getting hockey pucks right there to the chest, or baseball is very common in adolescence, et cetera. But on the other hand, you can't get it from a blunt injury like this. I mean, and it was too early for it to be, say, a direct cardiac contusion unless there was a direct injury there. It just happened so quickly. But it turns out that in Europe, they've had a lot of experience with this same kind of problem before, even just from a direct, like a shoulder hit or whatever. And Dean Malloy, he's the dean of the faculty of sports and exercise medicine at the Royal College of Surgeons in Ireland, has a lot of experience. And now he's the person that's sort of overseeing the procedures for this. So Mick, have you had those kinds of experience as well?
Yes, it's something that has occurred over recent decades and been more recognized. And I note in professional sport, it's a very different thing because you've got such huge teams and teams trained to respond very quickly. And that's the most important thing in this scenario. So having a team who are well functioning as a high class emergency response team, ready to get out onto that field very quickly after the person collapses, getting the automated defibrillator on, and then recognizing whether there needs to be a shock given or not. And the machine will tell you all that. In our scenario, we run courses called the CARES course, Care of the Athlete, Resuscitation and Emergencies in Sport, to make sure that our team physicians and team physiotherapists and trainers are all speaking as one when an emergency arises. I don't worry so much about the professional sport. It's more with the amateur sports and the kids sports that I get a bit more concerned, because there isn't the same level of medical care there. So I think having everybody trained in basic life support would be very important to reduce unnecessary deaths from these types of conditions. As Paul mentioned, there is a very specific cardiac cause in some of these circumstances where you get hit just at the wrong time. And that hit occurs at a particular electrical point in time. It just causes this ventricular fibrillation. And the only real treatment there is the defibrillator as quickly as possible.
What you're saying ultimately is an important part about, rapid defibrillation and obviously first CPR. But I think, people are concerned, should I begin CPR? We're talking now an out-of-hospital cardiac arrest that is outside of a football stadium, for example. Some people are obsessed with taking a person's pulse. And that really, has been a point of contention. If someone's unconscious and not breathing, we should start CPR. Wouldn't you not agree? They will wake up quickly, obviously, if you begin chest compressions, if they're not necessary.
I just tell people, just do it. And you're right, the people will wake up or feel it if they don't need it. Getting back to Nick's point, Dr. Malloy's point of having things ready to go. For example, 8 years ago, we had a professional player on the bench that suddenly collapses right there in front of the entire audience. We immediately did CPR. We got the AED on. We shocked, and he was ready and willing and able to get back on the bench again. And it turns out he had underlying coronary artery disease, but we got him back right away. I did this initial study where we actually wanted to see if the public would use these if we put it in a public place. And we did it at the Chicago O'Hare Airport. Most cardiac arrests occur at home, of course, but in public places, that was a good place to look at it. We had, almost 10 cases the first year. And what was fascinating was that we'd had almost no survivors over the previous decade, even though there were paramedics sort of on campus, so to speak, at the airport. But when we put these out there, we had 9 people go down that first year. 6 people had never operated one or seen one before. They just knew to kind of go get one or use it. Essentially, every one of those people survived, neurologically intact, and almost every one was waking up before traditional responders got there. That's how effective this is. But then you also have to know where the AED is. So we'll leave it at that.
Right. And how do you turn it on, as you say? Where is it? But then how do you operate it?
Well, that was the point, is that these rescuers that saved these lives there in the first year, it was like tremendous. You just, the 2 points I make about it is that, 1, you need to know where it is, and 2, you go turn it on, and it gives you the instructions. Follow through and just be in the Nike mode, because it basically won't hurt you, right? So it's rare that there's ever been any complication of that. The machine algorithms are so good.
Right. Nick, I wanted to turn to you about the European experience, specifically in Denmark. We know that there's a large public health initiative to have AEDs accessible. There's been multiple studies looking at how when the public's engaged, especially with studies looking at an app, when access is available, that survivability actually doubled in one recent study in the last 10 years. And just having the access itself improved outcomes. And so that was, pretty remarkable. In Ireland, for example, what's your experience there in terms of public access to defibrillators?
So we've got 2 different streams here. There was a big push to have more AEDs at all sports venues. That was great, but some of the sporting clubs put them inside the locked door. And we kind of went, no, there's no point, because nobody can access it. You need to have an external building, and you need to leave it open. And if somebody needs to use it, they know how to get it, open it, and get away, not get in through a locked door to try and get access to a defibrillator. So we have that now in most stadiums, and even small little rural areas where you might have only 200 people turn up for a game. We have AEDs in those units. But from another public access side, if you dial, in our scenario, it's 112, not 911. We have groups called community first responder groups. So in the rural areas, you have local people who've been trained up in basic life support and community first response who have AEDs. They'll have periods of the day where they come home from work as a teacher or a nurse or a policeman, a fireman, and they turn on an app on their phone and say, I'm available for the next 5 hours. If there's a cardiac arrest rung in within their 5 miles of their community, they will drive directly there with the AED that they have to that. And we've had numerous saves from that in the country, because it could take 40 minutes to get an EMS vehicle there. And obviously time is crucial in these scenarios. So our dispatchers will talk people through CPR, and then the community responders arrive with the AED, and it has been a fantastic initiative.
In many places, people have apps on their phones where they're locked into the system, and it will go off and tell them there is something nearby, and even GPS them into it. And it's been fantastic. And to 2 points I want to make to responding to what we just heard Dean Malloy say is, one is we always have a designated spot to have these in various places. So if I'm at City Hall, we always have near the red elevators on every floor, and then down at the security, or in all the public high schools, we always have one right below the clock where everybody can see it. You know, we set it up in a very standardized form that anybody will and everybody will know where it is at the time this event happened. The other thing he said, again, having the response teams is really fantastic. So I live in a high rise here, a large high rise, and there are actually 2 complexes, a lot of people here, and a lot of them are older, so they're going to be at higher risk for having an event. And we've had one just recently, in fact. And what the concept we developed here was a community emergency response team, where we have sometimes doctors, nurses, paramedics who live here, who will be on call, be responsible, or you could try to find one. But more importantly, we made sure everybody here knew where they were, and also, you know, not only where to get it, but we've got most of the people trained, and we're doing more and more in what actions to take during these periods of time when such events happen.
Yeah, it's critical. I also wanted to point out that we've looked at the use of drones, especially here in the United States. There's been some pilot studies looking at their utility in the setting of out-of-hospital cardiac arrest. I wanted to get both of your thoughts on this and the feasibility of this.
I think in a rural area, it's a fantastic idea. You're going to get something there as the crow flies very quickly. You'd probably have to look at exactly in, say, a rural area like Ireland, where 32,000 square kilometers, how many you'd have to put, what kind of distances they could realistically cover, making sure the batteries are charged. But certainly a very, very, very good initiative, because with the automated external defibrillators, you can't do anything wrong. You can't give a shock unless a shock is needed to be given. The machine directs you what to do. So somebody who has had no training can actually pick one of these out of a box and start to work with it fairly quickly and confidently that they can't do anything wrong. Great idea. Just a little expensive potentially at the moment, getting the drones and having that volume of drones around. In the US, you have completely different air traffic than we have, and you have a lot more in cities of helicopters flying around. We certainly wouldn't have that in our cities, but that could cause a challenge if you've got drones flying around as well. And it's about having it, making it safe, that nothing else can go wrong from that in somebody else's flight path.
Sure.
In my experience, the earlier the intervention, the better the results. So there is a limit here in terms of the drones sometimes if they just don't get there soon enough. Having said that, I've had situations, for example, we were so fortunate to have in the city of Seattle almost all the citizens knowing CPR, at least the majority, and we'd get that person resuscitated because they were doing such a good job with the CPR up front. The earlier the intervention, the better results. And that's really why you're going to see the Buffalo Bills player, survive neurologically intact, because he did get immediate treatment right then and there. And in the future, we may even have some better devices that will actually even restore normal blood flow right then there while you're even in cardiac arrest still. So I guess there's some limitations, as you say, in every case. But on the other hand, it's exciting, and it paid off in this particular case a week ago.
Right.
Just as a point of interest, coming from this small little country over here, the first portable defibrillator was actually in Belfast in Ireland.
Absolutely.
In the back of a cardiac response car. So despite us being a tiny little country, we do have some advances, even ahead of the United States.
That was actually a breakthrough. Dr. Pantridge and his registrar Geddes did this great work, and that caught the imagination of everybody here. At first, they were just going out to sort of give people oxygen and sedate them with their chest pain, and it turned out that their defibrillators is what made the difference there as they went out there. So absolutely, I have to acknowledge the folks in Ireland for getting this all, and that's how a lot of the EMS systems got started, because of that article published in The Lancet back in 1967.
Absolutely. I wanted to briefly mention and talk about screening of athletes at the high school, college level, but also at the professional level. And obviously, there are issues, including the risk of false positives in terms of low incidence, but also false negatives, as the case with Christian Eriksen, who had a cardiac arrest in 2021, who had been through extensive testing. So, we can debate the validity of such testing, but I wanted to get both of yours take on the utility of screening in such a population.
That's a very emotive subject because obviously, yeah, false positives are difficult because you're now saying to somebody you can't compete in your sport at a decent level. The difficult part is telling somebody this is the end of your career. The false negatives a little bit more difficult. I don't know Christian Eriksen. I'm not involved in his team in any way, but that is a 1 point at a time examination. And you're dependent on the skill of the person interpreting the ECG, which is, again, only a couple of seconds, and that particular arrhythmia may not have shown up on that. But also that athletes, by nature of what they're doing, they're operating at 99% of efficiency on a frequent basis. They are at the peak of their physiological fitness, and it does make them a little bit more prone to picking up viral illnesses from time to time. They may get a small viral myoepicarditis, which causes a new arrhythmia that nobody knew about. They had the screening through 2-3 years ago. They've now developed a new problem because of what they do, and which just may not show up. I was actually surprised that the gentleman himself, he came through it very well, which is fantastic, wasn't allowed to play football in the country that he was employed in, has now moved to another country and is playing football with a defibrillator, internal defibrillator inserted. I don't know what your rules are in American football, whether you can play with implantable defibrillators. I'm not so sure it's a great idea to do that.
One thing that we should bring up is that there are the athletes with the underlying cardiomyopathies or hypertrophies and things like that. And I just think that was unlikely in this case, but it's possible, but it's unlikely because it would have manifested itself before. So in terms of screening, I've met some very smart medical doctors who have run those, and they've been very just encouraged, even at the high school levels, to have screenings done, whether it's an electrocardiograph and or echoes, et cetera. So it depends, but I really have to echo also what Dr. Malloy has just said, is that it may have its downsides as well. But if you can pick up real obvious cases, I think that may be of value.
Absolutely. So I wanted to conclude and just get some pearls and takeaways from each of you regarding the events that transpired and what our audience can really hold on to.
If you look at Formula One in the last 50 years, in Formula One in the beginning, it was a 2-minute job to change a tire. Now they have this down where they're measuring in fractions of a second and criticizing each other if this guy is 2.6 seconds and the other guy is 2.9 seconds. I mean, for me, that's phenomenal. It takes me 25 minutes to change a tire. But we've looked at that from a resuscitation perspective, and we now do pit crew resuscitation before our events. We've planned our team, who's going to be occupying what role.
Yes.
After the events at the UEFA Championships, we had a new rule brought in by UEFA where they handed me a new document saying, this is what we would like you to do for resuscitation. But it was a 3-man triangle. And I said, no, we're not going to do that here. And they said, why? You have to. It's our rule. I said, no, our rule in Ireland is we have a 6-person triangle. So we're not downing our standards because of what you have internationally. You're governing games in some very low resource environments. I know that. But we have a particular standard here that we're sticking to. We have a 6-person group. We know what we're all doing. We come very quickly to those down players and get involved, and we've had good outcomes. So we're not going to change the standards. And I think that's the thing. You got to practice these things. The players don't go out on the weekend and do a move for the very first time without practicing it hundreds of times. We have to look at it the same way as the medical team who are looking after that group of players and the crowd, because we also look after the crowd, and we have to practice these events. And one of my particular challenges is in some of our stadiums, the upper decks are so steep. It's very hard to get a patient onto a trolley and do CPR as you're bringing them down to a zone to get them flat. So we've had to come up with some innovative techniques to try and do that and accommodate that, and using some of the mechanical CPR devices. That's the result you'll only get from having practiced these events and trying to extricate patients. You want to check response time. So you got to practice your response team activity very, very frequently.
I absolutely, and 2 points I want to again react to what we just heard the dean say is that one is the pit crew approach is critical in so many ways. And we did the same thing we call the medical first attack, where we knew who would be the AB person, who would be the C person. And actually, when we took it out to like the MBA trainers, what I've recommended for them is to have a similar approach. And then if it does happen right in the middle of prime time there, that they are actually coordinated. The second point is that we do mass gathering medicine. So it's not just the sports people on the field or the entertainers that we're looking after. It is the people in the stands, and we will see a cardiac arrest, once a month. If you think about it, you might see a cardiac arrest, occur in any community on a regular basis. And now you've got 100,000 people in one audience, and something bound to go wrong over those 3 or 4 hours where they're there and have some critical emergency. So preparation for all that is really important as well. And then the final point, though, I just think is that on a day-to-day basis, most cardiac arrests do occur in the home. Granted, 80% of them are not shockable kind of cases here, but the people who are more apt to survive are going to be the ones who have just an electrical event. In fact, when we looked at our data years ago, we found out over half the cases of people with ventricular fibrillation that we resuscitated, half of them didn't even have heart damage. Their enzymes were normal. So it really was a pure electrical event. They're very much more resuscitatable. They may have an underlying problem, but we can fix that once we get them back. So everybody needs to know how to do bystander CPR. And then secondly is to make sure we have AEDs strategically placed, as I kind of alluded to before. And we also go out to the other parts of the community and give them advice. So all those things have to be put in place, but more importantly, just get the training and then to make it simple. It's really the just do it philosophy, but make it simple. So for example, when I teach a course, I can do it in 15 minutes and people really retain it because I keep reiterating like, okay, there's one thing you need to know about choking, pop the cork, and you give them the physiological kind of image of what's happening. But that's what everybody says. They said, I remember you saying, just do it and pop the cork. With AEDs, you brought it up before. It's fantastic. Just know where it is. And that's really key. Know where it is. And that's why we should have it in standardized places. And go get it and turn it on and then follow the instructions as we saw before, et cetera. And then the most important thing is making sure you're doing quality compressions. And there are videos that can help you with that, let alone classes that you can take that will get you through it.
Absolutely. And the fact is that hands-only CPR, the public still has the misconception you have to do mouth to mouth, but that, that message still has not permeated through society, that you don't need to do mouth to mouth, that hands-only CPR is the gold standard now.
If people have a reversible cause like ventricular fibrillation, often they're already gasping, which is better than a delivered breath, by the way. And number two is that the most important thing then was the compressions to make sure you got oxygen going up to that brain. And because you're still theoretically loaded with oxygen in your bloodstream if you had a sudden cardiac arrest from a ventricular fibrillation. So your point's well taken. And we found that we had better outcomes when we just gave instructions to do compressions only. And that became the standard that you talked about now. Nick, you've had some experiences with that as well.
I was going to say, I think if we're going to have a long-term benefit from all this, we have to start doing this at elementary school and trying to teach kids basic life support and some basic health messaging. And I remember trying to get this across to a teacher one day, and the teacher saying, but why would we teach young kids to resuscitate each other? I said, I think you forget that the only 60-year-old person in the room is you. And if you train them and we train them, they're the one going to respond and keep you alive. And that's the way you should be looking at this. And that completely changed the mindset of whether we should be doing this for the kids or not.
Well, in fact, what we find is that that's exactly who gets saved. These kids are actually the ones that I've had cases after case where the kids at the school that had learned CPR saved the teachers or the administrator there at the high school or wherever it was, at the elementary school. So that's a fantastic point that you bring up, Dr. Millay.
One other brief thing we can interject here is just that the team was excellent on field in that they evaluated him in a primary survey sense of ABCs for things like a tension pneumothorax, because in the sense in which he was hit, there are reversible causes, and making sure he doesn't have a tension pneumo that caused the arrest, in my mind, was critical. And I think you would agree.
We do the same thing on a day-to-day basis in
Right.
a car wreck, because it could be that the person had ventricular fibrillation and had the wreck, so it's not trauma. And I think that's a fantastic point that you're making. And that's exactly what I think happened. And that's what we do.
Excellent. Well, thank you, gentlemen. This has been a really informative discussion. This is really helpful for our audience, and I appreciate your time and expertise.